This is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today we will hear highlights of a recent presentation by Dr. Tom Neilan discussing the broad spectrum of biomarkers that can be used to detect immune checkpoint inhibitor-mediated myocarditis. Dr. Neilan is an associate professor of medicine at the Harvard Medical School and director of the Cardio-Oncology Program. Don't forget to visit the ICOS website where you can find many excellent resources. And without further delay, here is Dr. Neilan.
So I'm Tom Neilan. These are my disclosures, just so I show them. I'm going to talk about cardiac biomarkers and ICI therapy. This is a relatively broad topic. I know we're being funded by a company who does serum biomarkers, but the reality is that the potential biomarkers for detection of cardiac toxicity are a little broader than just serum biomarkers. So when we're thinking about cardiotoxicity among patients broadly who are on cancer therapy or with cancer, these are some of the potential ways we can detect cardiotoxicity. Now, obviously, history is not traditionally thought of as a biomarker. And so if we narrow the list, we probably get to most of this. You can have serum biomarkers, you can have biopsy, which the cine function, cine image, MRI images, tissue characterization, echocardiography, which includes standard measures and includes strain imaging. But before I start to go into some of these different approaches for the detection of cardiac injury in the setting of immune therapy, I want to take a little bit of a step back. And what the report said was the single agent therapy 0.06% and combination therapy 0.27%. But if you've ever done work in this pharmacovigilance area, you can understand why that original report underestimated the incidence of immune checkpoint inhibitor myocarditis for both single agent immune therapy and combination therapy. And subsequent reports, mostly retrospective, have suggested a higher incidence. We now have good data, prospective data, protocol driven, which has given us a better estimate of the incidence of these things. And I'm going to focus on one particular study. I'm going to focus on this study. So this is a study in patients with untreated advanced melanoma published relatively recently in the New England Journal of Medicine. And in this study, patients underwent serial EKGs, serial troponins. Two groups of patients, one getting single agent nivolumab and the other group getting combination therapy between nivolumab and an investigational agent at the time, which was a LAG-3 inhibitor. And what they found was the incidence of myocarditis with single agent therapy with nivolumab was 0.6%. And in the combination with nivolumab and LAG-3 inhibitor, relatlimab, 1.7%. I want to talk a little bit further about those numbers though, and highlight some of the remaining issues with that study. So I think what that study shows is that the minimum incidence of immune checkpoint inhibitor myocarditis is 0.6%, but it's 0.6% plus a percentage. And what do I mean by that? I mean, in this protocol, folks who had a detectable troponin prior to starting either single or combination therapy were excluded. So if you had a detectable troponin prior to going on study, you were excluded from this study. And we know from there's a JCO paper from Dr. Brian Reaney, which actually suggests that the folks with a detectable troponin at baseline are the ones who develop major adverse cardiac events. And so this study excluded individuals with a detectable troponin. And so likely excluded a lot of individuals with pre-existing cardiovascular disease. Second thing, this study only did serial troponins up to cycle 3, day 1. The protocol therapy was given every 4 weeks. So cycle 3, day 1 was about 12 weeks. And why is that important? We know that the median time to development of myocarditis is probably, it's a little debated, but somewhere between 40 and 60 or 70 days. So a little over 2 months probably when you aggregate the data. But there are about 20% of cases or so which occur after 3 months. And so the figure of 0.6% is probably an underestimate when you use real world patients, i.e. those with pre-existing cardiovascular diseases, detectable troponin, and when you follow these patients out for longer. So what is the incidence? My best bet for single agent therapy is probably about 0.75 to 0.8% probably. And for combination therapy, in general, CTLA4 is probably at 1.5%, with LAG3 is probably higher and about closer to 2%. Indeed, we have 2 patients in-house right now who both got LAG3 inhibitors, who both have myocarditis. So a question I commonly get is, should a cardio-oncology assessment be recommended for all patients prior to immune therapy, and what should that assessment be? This is probably the easiest slide, and I think every patient should have a baseline EKG and a baseline troponin prior to starting immune checkpoint inhibitor. And that doesn't mean that we would stop patients from getting these life-saving therapies based on the results of these data, but they're highly useful to have if these patients present subsequently and we're trying to figure out, is this myocarditis? The next question is a little more controversial. Should we perform on-treatment surveillance for immune checkpoint inhibitor myocarditis, and with what? Well, let's take a step back. We know that the outcomes with immune checkpoint inhibitor myocarditis are fulminant. Case fatality rate of, in general myocarditis, maybe 2-3%. With this is, at least 30% and up to 40% in some series, just fatality alone. And if you look at MACE, major adverse cardiac events include cardiogenic shock, cardiac arrest, ventricular tachycardia, ventricular fibrillation. MACE rates are over 50%. And 38% occur in patients with normal ejection fraction. But in the center of this slide, I'm showing you the time from presentation from a study by Dr. Saad Mahmood. And again, most cases occur within the first couple of months. And so most cases are relatively predictable. And so if something, even though it's got a low incidence, presents usually early, then one can think about whether you should do routine surveillance. And if you were going to do routine surveillance, the next question is, well, what would you do with and what populations? So what would you do routine surveillance with? What are the potential options? A common question is, should we do routine echocardiography in patients who get immune therapy? The challenge with routine echocardiography is the left ventricular ejection fraction when they present with myocarditis is usually normal. LVEF is normal in 55 and 60% and up to 60% of cases in many series. So one cannot use left ventricular ejection fraction. And indeed, there's a nice study as well published in Journal of Clinical Oncology where they did apply routine echocardiography in patients getting immune therapy in the context of a clinical trial and found no value. So I don't think the routine use of measurement of ejection fraction has value here, either at baseline or serially in patients getting immune checkpoint inhibitor. But the cancer cardiotoxicity world has long known about the limitations of the measurement of ejection fraction in patients at risk of cardiotoxicity from standard cytotoxic chemotherapy. And so we've thought about other measures of systolic function, and these measures include global longitudinal strain. And indeed, when you apply global longitudinal strain, either by echocardiography or by cardiac MRI in these patients, one finds that in patients with immune checkpoint inhibitor myocarditis, there is a reduction in global longitudinal strain in patients with ICI myocarditis, both in patients with presenting with a preserved and a reduced ejection fraction. And that reduction in global longitudinal strain actually improves over time as you treat these patients. The challenge with the global longitudinal strain, though, is that there are elegant data, which I'm not showing in the interest of time, published in the European Heart Journal by Dr. Michel and colleagues, where they measured global longitudinal strain serially in mice and in humans and found a reduction in global longitudinal strain in mice and humans getting anti-PD-1 therapy, I think. That was not related to myocarditis and was just due to T cell infiltration into the myocardium. So that confuses the story about global longitudinal strain a little bit. So then I think it's complicated to serially measure global longitudinal strain in these patients because you actually don't know whether you're detecting myocarditis or detecting that normal T cell infiltration into the myocardium that likely needs to happen when any patient gets immune checkpoint inhibitor. How about cardiac MRI? Well, I think if you're going to think, it's tough to make cardiac MRI widely scalable. The expertise doesn't exist everywhere. It's an expensive technique. But if you're going to think about cardiac MRI in the setting, you would apply the modified Lake-Louise criteria, because applying late gadolinium enhancement or edema and black blood imaging alone has probably little value because many patients do not have late gadolinium enhancement or do not have edema and black blood imaging. And so, but if you're going to apply the modified Lake-Louise criteria, which are quantitative measures of T1 and T2, that certainly has value, but again, not a widely available technique. And each institution needs to standardize their own values. How about even more complicated? FDG PET imaging. Again, probably available in most academic institutions, but this group in France tested the value of FDG PET in patients with suspected immune checkpoint inhibitor myocarditis and found no value. In a study of over 30 patients who all got biopsies, the FDG PET signal was not different between those with and without myocarditis. So no value for FDG PET in the detection of immune checkpoint inhibitor myocarditis. The gold standard test, biopsy, or sadly in some cases, autopsy. And of course, that's not widely scalable, it's impractical. But in general, we biopsy the right ventricle in patients with suspected immune checkpoint inhibitor myocarditis. We don't tend to do MRI-guided biopsies to the area of worst injury. So biopsy the right ventricle, and pathologically, it's very similar to transplant rejection. And we'll often talk to our transplant colleagues, our transplant pathologists, and say, can you give us a grade? Because it helps guide immunosuppression. But all those are relatively impractical tests, or tests that are more practical and have limitations. What about standard tests? And the standard tests are the serum biomarkers, troponin, NT-proBNP, and EKG. And the beauty here is most patients have an abnormal troponin. The ones who don't have an abnormal troponin tend to be the folks who present very late with this kind of phenotype of a cardiomyopathy with no active inflammation that we don't quite understand yet. About 2/3 of patients have an elevated NT-proBNP. QRS duration tends to be increased in individuals. Many studies have shown also an increase in QTC, but the papers have differed in whether that's consistent, and if you correct using Friderenci as opposed to Bezet's, that the QTC effect might disappear. A lot of groups have asked, people said, well, maybe we should apply these standard tests in high-risk group, and maybe we should think about what's a high-risk group, which is acute coronary syndrome, heart failure, etc. Or maybe we should use machine learning for prediction of high-risk groups. But the reality is this group actually said, listen, let's do serial EKGs, serial troponins, and serial measurements of ejection fraction in patients in this clinical trial, Javelin Renal 101 trial. Found no value. Sure, having a detectable troponin at baseline, is associated with those folks who are more likely to develop MACE, and MACE rates weren't low. MACE rates were over 7% in the study, with a reasonably short-term follow-up. But serial measurement of troponin and certainly serial measurement of ejection fraction didn't seem to have value in this study. If one looks at other groups who have tested this approach of serial measurement of serum troponin in patients routinely who are getting immune checkpoint inhibitors, so this is a very nice research letter from JACC Cardio-Oncology by Dr. Hahn and Dr. Waliani out of Stanford, I think. And what they did was 214 patients, troponin I monitored at baseline and after each immune checkpoint inhibitor dose up to 10 doses. 11.2% had a troponin positive rate. And so roughly 3 patients in their study, a little over 1%, 1.4% ended up having myocarditis. But of the 21 out of the patients with positive troponin not attributed to myocarditis, thankfully only 14% had a subsequent delay in immune checkpoint inhibitor due to the troponin, which subsequently didn't turn out to be myocarditis. That's relatively good news because we're a little scarred from the data where we serially measure ejection fraction in patients getting HER2 inhibitors, and we stop HER2 inhibitors because the ejection fraction declines to 48% in a patient who is free of clinical heart failure. And the black box warning says you got to hold the HER2 inhibitors, when in reality we know that you probably can continue to treat many of those patients, true. And number two, we now know for definite that stopping HER2 inhibitors has a major impact on cancer outcomes. But maybe there's a window here for thinking about serial testing or serial surveillance in patients beyond the use of troponin. And this is a screen grab from a very recent American Heart Association presentation only last weekend. So apologies for the quality. This group from Michigan, led by Dr. Hayek, they said, okay, how about we apply things like AST and ALT, LDH and CPK to patients who are getting immune checkpoint inhibitor therapy? And do we find value in that approach? And so they serially measured AST, ALT, CPK, and LDH in these patients. And what they found was, that patients tend to get an elevated CPK before they get diagnosed with myocarditis. The elevated CPK it has a sensitivity of over 99% and a specificity of 23%. And so this group in Michigan have adopted this approach where they screen for immune checkpoint inhibitor myocarditis using CPK, AST, and ALT measurement every 2 weeks for 12 weeks after immune checkpoint inhibitor initiation. If the CPK, AST, and ALT are increased, they check high sensitivity troponin. If high sensitivity troponin is abnormal in someone who's asymptomatic, they say it's possible myocarditis, and they rule out secondary causes. They do close monitoring with a repeat troponin in 48 hours, and if it's rising, they say this is high risk for myocarditis, and they admit for workup. They rule out other causes of myocardial injury and have a lower threshold for initiation of corticosteroids plus abatacept. If they're symptomatic and the troponin is normal, they say this is probably myocarditis. We admit for workup and likely treat with corticosteroids. If the troponin is normal despite the CPK, AST, and ALT, then there's no myocarditis, and they continue monitoring with repeat troponin about a week. I mean, this approach has a lot of logic behind it, because if generally these immune checkpoint inhibitor adverse events like hepatitis, myositis, and myocarditis, pneumonitis also, they tend to flow together. And so if the patient is getting, the logic behind this is that they're getting hepatitis and an elevated CPK, then they're probably at higher risk of developing myocarditis as well. Common question is troponin I or troponin T? And so if we're going to do a serial approach, would we use troponin I or troponin T? And you know, the recommendations, which I'm going to highlight here, say that cardiac troponin I is preferred, especially if suspicion of concomitant myositis. And so, sure, use whatever troponin you have available if you're worried about myocarditis, but troponin I is preferred. The answer is we don't really know if that is correct or not. And I want to highlight a very recent presentation at the American Heart Association, again, relatively hot off the press. So this is a picture of their poster presentation from Dr. Zhu and colleagues in Roswell Park, which is a major cancer center. And what they did in this study is they did two things, right? They did a mouse study and they did a human study. And the image on the top left is a computer algorithm-based approach where they said, okay, predict for me the 4 peptides which had the greatest potential for immunogenicity in patients getting immune checkpoints, 4 peptides on cardiac troponin I. And they came up with a list of 4 of these peptides. And then they measured these peptides in sera of mice and in the sera of humans who were getting patients who were getting immune checkpoint inhibitors. And what they found was this cross-reactivity to peptide T4 and peptide T5 in patients and in mice, both at baseline and those who get immune checkpoint inhibitors. Now, this wasn't a myocarditis study. This is just all comers who, obviously all comers in mice and all comers in patients who get immune checkpoints. And what this suggested was that you can get an antibody to cardiac troponin I routinely. Now, antibodies to troponin I are common antibodies. They can be seen in normal healthy populations and up to 5 to 6%, and in disease up to 20%. And so what they postulated was that maybe some patients who develop these cardiac complications from immune checkpoints maybe have a pre-existing antibody to troponin I. Now, if you believe that, which seems highly plausible, one would question then whether we should use troponin I or troponin T, because if you've got antibodies to troponin I, maybe that's why some of these patients have a falsely negative troponin I, yet despite having pathologically proven myocarditis. We don't know the answer, and it's an area of active investigation. But we've had several individuals now admitted to our center who we've sent both troponin I and troponin T on, high sensitivity, where the troponin I has been undetectable or nearly or at low levels, and troponin T is significantly elevated. And pathologically, these patients have turned out to have immune checkpoint inhibitor myocarditis. So the answer is I'm not sure whether troponin I or troponin T, and it needs further investigations. So putting it all together, so the Jörg Hermann and Dan led this paper in European Heart Journal in 2022, a consensus diagnosis for diagnosis of immune checkpoint inhibitor myocarditis, which uses either pathohistological diagnosis or a clinical diagnosis. And the clinical diagnosis is based on troponin elevation using either cardiac MRI or some minor criteria. And again, in this, we also said both troponin I and T can be used. However, T may be falsely elevated in those with concomitant myositis. After seeing that, those data from American Heart Association presentation out of Roswell, I'm not entirely sure now. The group led by Dr. Hayek out of Michigan have a more simplified approach. If you present with symptoms and your troponin is abnormal, right, and your time to ICI is less than 60 days and you have an elevated CPK, you have a stably elevated or rising troponin, then you likely have immune checkpoint inhibitor myocarditis. You rule out ACS. If you don't have ACS, then what else can you have? And you start immunosuppression while completing the workup. And so this would be a more inclusive approach to with a higher sensitivity than the approach which was suggested in our publication, European Heart Journal, but probably a slightly lower specificity. How about treatment approaches based on serum biomarkers? Well, we know about pharmacological. If you have myocarditis, there's two approaches, pharmacological and non-pharmacological. And the pharmacological stuff is corticosteroids with a dose that's debated. Most people default towards higher doses of corticosteroids, but even that is an opportunity to be tested, because I'm sure there's some individuals where we could get away with intermediate doses or lower doses. We do know that troponin levels are associated with outcomes. Higher troponin levels at admission, higher troponin levels on therapy are associated with major adverse cardiac events in patients with immune checkpoint inhibitor myocarditis. We do also know that CK, CKMB at admission are both associated with worse outcomes. So the image on the left is troponin, in the middle is CK, on the right is CKMB. And this is a study, I think, of about 25 odd patients who got both. So CK, CKMB are also associated with worse outcomes. And in unpublished data, there's a suggestion that troponin trajectory might be associated with worse outcomes. So those patients who come in with a troponin, you start them on corticosteroids, but their troponin doesn't drop or sadly increases. It does look like, when you look at the curves on the left and right, between no event and event, and you put your troponin trajectories, I think you can probably make out that the troponin stays relatively flat in this blue line or decreases among patients with no events, whereas there's an acute rise in those who will go on to have an event. So maybe when we start these individuals on corticosteroids and we look at their troponin response, those troponin kinetics, may associate with subsequent MACE. And we can use troponin in other ways for thinking about should we add additional immunosuppression. This is a study of this is a single report of patient myocarditis from combination immune therapy, comes into hospital, gets diagnosed, troponin is up, right? Troponin does not respond, right? The patient develops complete heart block, VT, and cardiogenic shock, gets into their ICU, gets a single dose of abatacept at 10 milligrams per kilogram, and you can see the troponin drops, and just after the troponin drops, the patient comes, develops goes back into sinus rhythm and off all vasoactive agents. But we need more and higher quality data, that's for sure. And we need more and higher quality data because we're giving lots more corticosteroids. And despite the fact we're giving lots more corticosteroids, the rates of major adverse cardiac events remain high. So despite the escalating doses of corticosteroids, rates of MACE remain at over 50%. And we know that high-dose corticosteroids really impact the cancer outcomes. So we may win the battle, which is myocarditis, but we are definitely losing the war, which is overall mortality and cancer outcomes when we use such high doses of corticosteroids. And hopefully some data will come from this randomized trial. It's a plug for the Atrium trial, which is a double-blind placebo-controlled clinical trial, which is recruiting at 50+ centers throughout the United States and Canada, and where we're also serially measuring biomarkers, including troponin, NT-proBNP, and a couple of other plausible biomarkers. And hopefully you can look at those levels in a protocol-driven approach as well as a response to therapy, and give us a better understanding of kinetics, difference between troponin I, troponin T, etc. in this population. So last slide, I want to thank you for the opportunity to present and the invitation.
Well, that was another excellent presentation by Dr. Neilan, and I'm sure that you enjoyed it. You can learn more about cardio-oncology by visiting the ICOS website at ic-os.org and by attending the GCOS Summit this September in Madrid, Spain. Until next time, this is Dr. Tom Murtaugh on behalf of the International Cardio-Oncology Society saying, treat cancer, protect hearts.